You can see just with those two speakers, I could not be prouder of my colleagues and the work that they do, not just nationally, but internationally, and the effects that they have on, current generations and generations to come with the growth and the development, not just in the moment, but making sure that their legacy goes on. Now, last but not least, and I think a very interesting lecturer, I've heard him in the past, I want to introduce Dr. Eric Miller, DO. Dr. Miller was born and raised in Covina, Southern California. He graduated from Cal Poly Pomona with a BA in political science. He attended the A.T. Kirksville College of Osteopathic Medicine, which is the original College of Osteopathic Medicine in Kirksville, Missouri, and graduated with his DO degree in 1999. He completed an osteopathic rotating internship at St. John Detroit Riverside Hospital in 2000, and then went on to a general surgery residency at Oklahoma State University Medical Center, known as the largest osteopathic training program in the United States in 2004. After practicing general surgery in Michigan for 6 years, Dr. Miller and his wife Melissa and their 2 children traveled to Albertville, France to attend immersion French language school for 18 months. That sounded really cool. In late 2012, he and his family traveled to rural Togo, West Africa, to join the work at Hôpital Baptiste Biblique, which is the Bible Baptist hospital, where he worked as a missionary surgeon, and the family stayed full-time until September of 2017. Upon returning to the U.S., Dr. Miller joined the faculty at Liberty University College of Osteopathic Medicine, where he currently is an associate professor of surgery and chief of surgery in specialty medicine, and serves as director of third-year medical student clerkships. Currently an active general surgery practice with Central Health in Lynchburg and Bedford, Virginia, Dr. Miller precepts third-year LUCOM medical students, the College of Osteopathic Medicine, in his practice, and co-leads short-term trips with fourth-year LUCOM students to overseas hospitals in Togo and Kenya. He hopes for Melissa to accompany him on future trips overseas. Welcome, Dr. Miller.
Let me see if I can pull this up now. This is our start of the day. I just want to thank the International College of Surgeons for allowing me to speak with you today. And as you can tell, I'm doing this lecture a day early. No conflicts of interest disclosed. All right, so some objectives today, and actually, this is not advancing, so I'm reading down there. Sure. Yeah, I'll just read there we go. Yeah. Okay. Sorry about that. So really today, I wanted to share a little bit about myself and my family, relate my path taken to becoming an osteopathic surgeon. So I will start off by saying, you might not have heard much about the actual osteopathic part of it. What is an osteopathic surgeon? Well, I don't know that there is actually an osteopathic surgeon. What it is an osteopathically trained physician in the United States who trains to become a surgeon. That's what I am. And then the path toward entering emissions medicine. And I'd like to talk a little bit about healthcare problems. I think that's been covered very well already. And briefly describe the Hôpital Baptiste Biblique in southern Togo. There is actually a second hospital in northern Togo called the Hospital of Hope, Hôpital de l'Espérance. And so some of the major surgical problems seen and treated in Togo. This is going to be a very technologically light lecture because technology, as you saw in other austere situations, is not a we don't have the ability to use things like MRI, CT, C-arm, things like that, robotics. In fact, on the previous lecture topic of robotics being trained around the world, it's a wonderful thing. But I did notice on the map that Africa looked pretty blank in terms of the ability to get robotics going. And the West Indies appears the same, even with laparoscopy. So, also I want to talk about the dreams of the future and current fulfillment of these dreams at this hospital in Togo. So, Dr. Ponte did a great job already of introducing kind of my story. A couple of things to think about, though. You might look at me as a patriot of osteopathic medicine. Everywhere in the line of my training has been through an osteopathic program. So graduating in '99 from A.T. Still University. Why A.T. Still? Well, Andrew Taylor Still, MD, was actually the who actually founded osteopathic medicine in Kirksville, Missouri, and that's where the school started, and then the entire philosophy of osteopathic medicine, which now has, more schools keep coming up every year, so 73 schools of osteopathic medicine now. And it is still uniquely American, it's uniquely United States training. There are DOs, though, in other areas of the world, such as Great Britain or France, but that is actually a different training. That is not training in all aspects of medicine and surgery. So American trained DOs you'll see in things like the ACGME match. That has to be who enters that match. And in fact, the Oklahoma State University is part of the ACGME program now. And so, one of the things, let me give you a peek into what osteopathic medical school is like. It's very much the same as allopathic, which is going to be MD training, or MD-BCH training, or MD-BS training. Very similar in terms of the basic sciences, pharmacology, surgery, and all the organ systems. But the difference is we are trained in osteopathic manipulative techniques, but also the osteopathic course is really a philosophy course going through the first 2 years of training while still in the classroom in medical school. So each of the three of us have been through all of that training. Doesn't mean we necessarily practice osteopathic manipulative treatments because we are trained as surgeons, and so most of our time is spent in surgical practice. One thing I will say, though, is about the philosophy, and this is what, does osteopathic training turn somebody into somebody who has the osteopathic philosophy? Probably not. I think what it did for me was it allowed me to practice what I already had a goal of doing, and that was treating and taking care of the whole patient. Who's the whole patient? If you just look at yourself, look at your body, look in the mirror, think about things, and even imagine eternal existence, that is what a whole person is. And so while I or my colleagues may be called on to perform surgical treatment on a patient, what I'm thinking is my goal is how do I find health in this person? In fact, of all physicians in the world, who among us are thinking to ourselves, how does this person become healthy? What is the problem causing this person to be unhealthy? So I would challenge each one of us to think about that. And so, is there a root cause? In fact, I would even ask you, if you're in your practice, you have a patient come in who's supposed to have a surgery of some kind, and you see that they are taking 15 medications. Well, those medications are treating things, but would you consider that a healthy patient? 20 medications? I wouldn't. I would think there's something seriously going wrong. What role can I have in that? Now, I am limited because, again, the focus of my practice is surgical. But my goal in every patient encounter is to try to figure out, what can I do to help this whole person get better, in addition to whatever I'm going to do for them. So that's a little bit about osteopathic philosophy. So as you already heard, from 2011 to 12, we started in Paris for language training. Went to Albertville, took immersion French, started a full-time mission practice in Togo, West Africa. So this is with an organization, so we didn't have to start an organization. It was with the ABWE, which is a Baptist organization, and it is a Christian mission, which I practice my Christian faith, and we help people to understand the Christian faith, and as a follower of Jesus Christ, that's really the goal of my life. So in 2017, my family and I returned to the USA to do common faculty, and my real passion now is actually going to what I consider the root of the tree, or the beginning of the pipeline, so to speak, and that is medical school. So training medical students is what I do, and I really get excited about our medical students who are so interested in going out to the world and being able to help people in the global environment. So my wife, Melissa, and I first went to Togo in 2005, so that's us on our first trip. This is our family with Melissa, Sam, and Lizzie coming back actually to the HPV hospital after our furlough. So this was re-entering the hospital compound, so it's a great day. So this is Sam, my son, then and now. So he's a fan of the National Treasure movies, so National Treasure 2, that pose is in there, if you've ever seen that movie. If you haven't, it's a pretty funny movie. Good one. But that's Sam now. Lizzie is my 16-year-old daughter, so you can see now she's this beautiful girl. She's always been a beautiful girl, but back in Togo on the swing, and then once we first got back to the United States, she got into the martial arts, and that 5'2" could kick me in the head. And so she is something else. So we went to France for language school, where we got to actually live in the French Alps. We thought that was pretty cool. The hills were alive with the sound of music. And then on to Togo. So Togo's in West Africa, where situated between Benin and Ghana, small country. Lome is the capital on the coast. We were up in the rural area about mid-Togo. And this was funny, there's a movie called Dave about a fake president who, Ben Kingsley is the vice president, and comes back with a gift from the king of Togo. And we laugh at that because there's no king of Togo. And so it's actually, there's a president and prime minister. But going into the mission field, I think anybody who goes into austere situations where it's really limited in resources, you kind of feel like these two spies like us, Chevy Chase and Dan Aykroyd, where they're trying to do surgery without many resources. So a few things about Togo, some history of it, very, I would say, overall impoverished. You can see by the per capita income, that's annual income. And then President for Nasingbe is actually now, as of 2024, he brought in a constitution, a new constitution, which allowed him to be prime minister, which he is now. And now there's an elected president, which is term limited, but the prime minister has 6-year terms and it's indefinite. And so the Nasingbe family has been basically running Togo for decades and decades. So it's kind of a situation where Togo is officially considered a partially free country. And so it's kind of a tough place. And so official language is French, that's why we had to learn it. There are many other languages. So healthcare, there is actually a medical school and university hospital, Centre Hospitalier Universitaire in Lome, and however, there are money problems, and so they obviously can't treat everybody in the country there, and there are very few doctors overall. So getting into toads on the beach in Lomé. These are some of the fun things we find around the house. And outside, there are some very poisonous snakes. Thankfully, being on a hospital compound, we had anti-venom. But this mamba decided to start heading toward my house, where my family was. So I went from being afraid to approach it to getting kind of angry at it. He didn't win. And so, in fact, I got to meet with the chairman, actually, of surgery at the university hospital, and just officially invited him. I said, you know, we'd love to have you come up to our hospital, tour, do all these things. And he goes, well, I'm probably not going to come. You have too many snakes there. So that was his. So for our neurospine surgeons, this is the dream or nightmare patient. Lots of heavy things being carried around. A little bit of a funny thing, you know, you might find out there. I can't actually explain this sign, but it was funny. So how about you know, some of the chaos you might run into? So us and the truck to our left are actually on the right side of the street and going in the right direction. Everybody coming at us for some reason is in our lane and has taken over the right of way. So that's how it can go. So this is our hospital, this is the compound where we live. So some things that we had there at the hospital, pictures from the hospital. And this is just how things looked. So I'll move on just to talk about this a little bit. So the healthcare system, there are actually many private medical surgical clinics, but no real system of health insurance. Though there is some type of health insurance, but really only for the wealthy. So the poor can really only get health care if their extended family or friends prepay the bill. And so that's a problem. In fact, we found ourselves doing a lot of orthopedic trauma. And one non-union femur fracture we needed to repair was, and somebody sat in the university hospital for almost 2 months because they didn't get the bill together. Okay, so the mission, you know, we do this as a Christian mission. We want to share the name of Jesus Christ with people. And so services, really almost all types of medical services and surgical. Now there's actually a PACS, or Pan-African Academy of Christian Surgeons, general surgery residency training. So a little bit of the history, some of our founding and original doctors and surgeons. And now this is, so I'm there. Tom Kendall, Dr. Kendall is actually the current hospital director. So this was kind of a bridge time between our origin history and current present day. So now we have Dr. Jack Patel and Tom Kendall. Jack Patel is actually the residency program director for PACS. And these are the PACS residents. So these are all a dream come true, really. This hospital existed since 1985 without any kind of ability to train surgeons. And now we have surgeons training there to stay in Africa, practice general surgery, all aspects of general surgery, take care of their own communities or in other countries in Africa. So there are many short-term visiting surgeons, and that's how I was able to survive the time I was there, was having great help come, including many osteopathic surgeons. So osteopathically trained surgeons would come in and help as well. Dr. Barant, who Dr. Pumpkinshire as well, came in. Dr. Bayrite, our OBGYN dream team, and then up in the Hospital of Hope in the north, we had our other osteopathic surgeons who would come in regularly to help. This is just a picture of the two hospitals' OR staffs. So these were great people to work with. And then I just kind of shout these guys out, and I had the opportunity to mentor them in many ways, including spiritually. So, of course, David Dowd would be our anesthetist. So this is our OR. We're probably not going to fit a Da Vinci in there anytime soon, but we also hope to progress to laparoscopic surgery, as Dr. Patel talks about one But mainly we had to rely on open surgery. So what are some things being done? Hernias are really the most common thing being repaired. They can be pretty big. So hernia sacks the size of volleyballs, because people go well into their adult years without treatment of hernias that just don't grow, especially these scrotal hernias. But also tumors, and so for plastic surgeons, some of these were so large, I don't know that we could have done any kind of flap in the situation, so we had to heal them and get them to a point of at least getting skin graft. Yeah, we did have wound back here, and that was very useful for us. So different kinds of problems we would see, and again, this is the general surgery practice that we got to do, and this is not something necessarily we get to do all of in the United States. So some amazing things we would see. Infectious diseases. Unfortunately, necrotizing fasciitis happens everywhere. But wound vac therapy really was a saving grace for us. And in fact, the inventor of the wound vac from Wake Forest, he had brought a team of plastic surgeons to Togo years back, and he supplied, has allowed Wake Forest to supply vac equipment for years and years. Ileal perforation due to typhoid fever is one of the most, that's what I consider Togo's appendicitis. It was that common, unfortunately. So these were obviously surgical problems. This is what that might have looked like on the inside. And acute care surgery, that's the daily practice. So strangulated hernias, unfortunately, are very much an emergency. Left duodenal ulcers, just like we see here, often have to be treated. Unfortunately, there can be procedures done at childbirth, even out in villages, and they may present as abscesses afterwards. So skin grafts, things like that. Trauma, so trauma was a big part of what we did. Spinal trauma, like we might see here. The thing about trauma in these situations, there are a lot of motorcycles. And so motorcycles are most of the vehicles on the road, only a few cars and trucks. The motorcycles don't travel very fast, so there's not a lot of high-speed trauma. But the trauma is still significant, and many times it's on people who are not wearing helmets on the motorcycles, so we get a lot of head-to-face trauma. I've only seen this once, fractured pancreas, where somebody was actually pinned between the front of the car, and his animal, like a cow, and unfortunately left for hours and hours before somebody discovered him, and so came in with a fractured pancreas. Orthopedic trauma was kind of an everyday thing for us. ORIFs, a humerus fracture here, and these were things that I and my colleagues had to learn kind of on the fly, if you can believe that. For orthopedic trauma, it's having a good orthopedic atlas and a good plastic surgery atlas were life-saving for me. So these were some of the things we do. We do ORIFs of tibias and femurs using the SIGN nail program. So anybody who works in these situations is probably familiar with SIGN, who was out of Washington State supplying all this equipment. So it'd be funny about that, but yeah, the leg's not supposed to bend like that. This is a story. This is a story of how how a general surgeon can do a record number of surgeries on one patient in 1 week. This is a patient who was on a motorcycle, was hit in the back by a truck, and flew off. Came in with bilateral femur fractures, a right radius ulna fracture, and unfortunately a lacerated spleen, or ruptured spleen. That spleen you saw before, that's his. So looking closely, it's hard to look closely on this picture, but he's got a midline laparotomy scar. It was obviously the first priority was to take care of, do trauma laparotomy and take the spleen. Then we brought him back, let him recover for a few days, and once we knew he was stable from the spleen, take him back in, do an ORIF of the radius ulna fractures, and then let him recover another couple of days, and then we took him back and did sign nails on bilateral femurs. So those are times when you think, I wish I had a lot of surgical help, and I didn't at that time, so we had an awesome family doctor who was there who assisted all these surgeries. So this is the sign nail where we have this kind of system where we don't have to use C-arm. We're able to do an open reduction of the fracture. You can see the nail entering at the knee. It's a retrograde placement, but using this arm, so to speak, we were able to place the screws. We couldn't use experience, like Dr. Patel was talking about, because you just can't see where these screws are going. You have to fit it through the nail and through the bone. But using this device, we were able to do that. So there's the post-reduction picture. And these incisions are probably much bigger than orthopedic surgeons would use, but we need to see what we're doing. So we would also have these patients do a squat and smile picture so we could upload these to the database. Now this is that patient. He had this splenectomy, had his right arm, wrist fracture, ORIF, and bilateral femurs. Now, that's not the best squat in the world, but our goal is to get them squatting like this. And so these two were actually on a motorcycle accident together. They were both riding on it as passengers, and both had a femur fracture. Other things, motorcycle trauma, the chain trauma, and so this kind of brings up another kind of funny story about how we would treat wound care. We clean these up. Some of these we just couldn't salvage. We just had to treat it as a wound. But thinking osteopathically, I thought, how can the nutrition be improved? I was thinking about nutrition of these patients because, we all know that, right? They're not going to heal wounds if they're malnourished. And so I had come upon the discovery of using moringa leaf powder. And you can go to a vitamin shop and get that now, a bag of moringa leaf powder. Well, we could grow it. So grow it, make it in powder, and I would take a bag of this around to the patients in the wound ward and try to instruct them to use it in their soup or whatever they were eating. Well, this patient had actually, we came back to see him and took his dressing off the next day, and there's moringa all in the wound. And so it didn't hurt him. And so we thought, okay, but usually eat it. We want you to eat it. Yeah. So we would do X-Fix and burr holes. We would do this with our trusty atlas, trying to figure this out. But we would do burr hole and use a gimli saw, try to do a mini craniotomy to decompress these patients. Facial trauma was tough. We saw a lot of that, where we had to, they're messy wounds, of course. And then machete trauma, lots of fighting sometimes between village men, different village men. And so maxillofacial surgery was something we did a lot of. And of course, open dislocation there. Another machete, this was one this one went right through the maxilla, so we had to do some maxillofacial wiring and suturing, things like that, to get this back together. Burns, heartbreaking. These are heartbreaking situations where kids would basically fall into the fire that their mother usually had going at the roadside, and many cannot be saved. So tough things. But we did rely, the extent of our radiology was plain film and ultrasound. And so many of our procedures were ultrasound guided. And so we were able to drain abscesses and do different things like that. This one was a pericardial effusion, which was thankfully able to be done if you can get to them on time. So we even had well-known trauma surgeons from Orlando, Florida, come out and do general surgery. So that was really, really cool. So pediatrics, again, sometimes heartbreaking. This is my version of dad joke humor, that when we would get pyloric stenosis, you look for an olive sign on physical exam. This one had an olive wrapped around the waist. So there it was. So there's that pyloromyotomy. But, you know, these were actually rare things we would see. Things like duodenal or jejunal atresia. This particular one was a jejunal atresia patient, so 3 or 4 weeks old. You know, you know, every surgeon knows what a sleepless night is like when you've done an operation and now you're basically praying for that patient to come around. And that's this one, because we didn't have the ability to use TPN. We didn't have the ability to feed yet because we didn't know if the bowel was working yet. So we had to wait, I think it was 3 days, just with this patient getting IV fluid until bowel function returned, so we all jumped for joy, of course, when that happened. So Hirschsprung disease with pediatric surgeons. My role in this kind of situation was, I'm not a pediatric surgeon, so I would actually take them in and do a resection of the sigmoid and give them basically a Hartman colostomy procedure until the pediatric surgeon could come and be able to come in and do a ileoanal pull-through. So other things, testicular torsion, intussusception. Don't you hate when you wear your shirt and someone else is wearing the same shirt? And so some cultural things. Petting zoos are a little different than what we're used to here in the United States. So yeah, gotta be careful with that. But we did find a cat that we brought home with us from Southern. Okay, so dreams of the future. We all dream, right? We dream about building, and the HPB hospital is in the process of renovating the center. So these are some drawings there. Medical education. This is huge. This is huge. Keeping it going. And so simulation. We talked about different simulation. We had this doctor you see right there is named Audrey Bonza. Dr. Bonza is from Congo. He came over to us, spent 6 months with us as an intern, basically a house officer in Congo, came over and was wanting to do surgery. So one of the things we worked on, because we do so many ileal resections from typhoid, is we did this hand-sewn anastomosis, resection hand-sewn anastomosis simulation using the stockinette, vessel loops, and plastograph. And so he learned how to do a hand-sewn anastomosis. And Audrey Bonza then went on to train at Galmi Hospital in Niger with the PACS program, and he is currently an attending surgeon. So we also, for our medical students, we train our second-year surgery-interested students in fundamental laparoscopic surgery. So we do that program every year. We run them through the entire didactic and skills course so they can learn these things, get out on their rotations, and then when they're in their 4th year looking at programs and going into programs as auditions, they already know this. So they've been through the entire FLS doing that. So it's something we can do, so I'm really happy and proud of these students. Dustin is now a fellowship-trained general surgeon in Idaho. And so we also have these osteopathic medical student international rotations. 2018 was LUCOM's first graduation class. They started in 2014. So this is Dr. Patel now. She's a student doctor at the time, learning chest tube. She and her husband, Josh, who's also a DO, were doing presentations. They were doing osteopathic manipulative treatment, doing some cultural things. And now Nicole is at VCU in cardiovascular medicine fellowship. Josh is an OBGYN now and has finished a maternal fetal medicine fellowship. So I'm so proud. You can see it, you can hear it. I'm proud of these students. And we had OBGYN residents actually come and train at the hospital as well. So these are some of the resources. ABWE International, that's who most of the missionaries or most of the surgeons or workers who go to these hospitals go through ABWE. But there are other ways. Samaritan's Purse is highly involved in this. Operation Getting Back with FACS.org, and of course PACS. Okay, that covers it. I'd like to thank you for allowing me to be with you.
Thank you. That was amazing. All three of you, this was an amazing morning. I first want to say thank you and God bless you for doing that work, and everybody in this room that does missionary work. Your work exemplifies what it is to be an international surgeon. And I invite all three of you to apply for a fellowship because you truly are international surgeons. And Josh, I think you can echo that. This is the type of surgeon. This is our mission statement, and you exemplify what the mission statement is for this individual little club we have. And I was proud to have you guys be part of it. As far as questions, there's some, yes?
Thank you so much. I'm Dr. George from Japan, and I am a maxillofacial surgeon. So I was impressed with your widely experienced expert surgery. And I have a question as for the maxillofacial trauma. Okay, the soft tissue injury is okay, just suturing. But how do you need to deal with the maxillary or mandible fracture fixation with titanium mini plate and screws or wiring? This is my question.
Okay, thank you. Well, thank you, and I would love to have you there for some of these, and so thank you for what you do. For the soft tissue, as you said, is getting those together. The hardest ones were, of course, when they would come across the lacrimal duct, and we would have to figure that one out, get some sort of stent into it, and actually suture it with a very, very small suture. And we thank Ethicon, by the way, who actually did donate suture to us. But for the maxilla or mandible, for mandibles, we didn't do plating. I didn't consider myself well trained for that, or trained at all for that, and I felt like it was too much to try to do. So I basically used arch bar type wiring for mandible, and so those were effective. But we'd keep them in the hospital until we were able to get them to the point of eating again. For maxilla, what I had to do, and I for better or for worse, I used steel sutures to wire those. And so I felt like in those situations when I could approximate those properly, and if the nerve wasn't involved, which they weren't, I never had to deal with a nerve injury in those situations, the orbital nerve. But wiring for the bone, and then sutures, layers of sutures for the soft tissue.
How about the condylar fracture of the transmandibular?
I did not deal with any of those.
Okay.
Yeah, so I wouldn't have done that.
Thank you very much.
Yeah, you're welcome.
So I have a question, and kind of alluded to this, is that the acronym DO or osteopathic medicine is really not known, is limited knowledge of it outside of the United States. Would you encounter any curiosity when you go to other countries about what that meant to be DO? And I think that Dr. Patel mentioned being licensed to these countries. Was there a different set of questions that were asked, or did you have to provide some education to help them understand what that meant?
I think that some likely do. In my experience, I had not had to do that. I wanted to bring up for licensing, it is not easy. In fact, I think a lot of DOs feel like foreign medical grads into the countries they want to practice in, because it's not as easily recognized as an MD, as an MD, BCH, etc. And so for us, there's been a lot of advocacy from the American Osteopathic Association to go into these countries, and actually the one for Africa is called the AMCOA, the Association Association of Medical Councils of Africa, which is a 20-country group. That entire group is recognizing of DO education. So it's the degree that is the question, and you're absolutely right, that's what gets the questions. In fact, even at dinner parties in the United States, that's humbling for myself and colleagues to have people say, well, what's a DO? And so I do like to explain it. Again, I'm a DO patriot. But in these AMCOA countries, they are fully recognized to be able to practice all aspects of medicine and surgery and become licensed in that country. Yep.
Josh, several years ago, I had gone to Nepal, and part of it was submitting all my qualifications to do some missionary work there. And I actually reached out to Nick, because I had submitted everything to the hospital. I had American boards, fellowships, training, microburn, all that. He gave me an International College of Surgeons card that signed off on what my qualifications were, and I had submitted that and it helped. So maybe we can offer some sort of thing that you're an international surgeon and you're traveling to other countries. This would help all of us just to say, yes, we are surgeons. It doesn't matter what our initials are after our name. We're still qualified to go.
So for Togo and Kenya, what I did need to do practically was just what Tony was talking about, and that is I had to supply my credentials, which is my license from America, from Virginia actually, and I had to supply not my degree, my diplomas from residency and everything to show that I was trained in general surgery as well.
And so, as we know, there's a million medical degrees out there. MBBS, I've seen some weird British versions of it too, MBCH or something. So these countries know that there's a very degree set in the world. So their licensing application, a lot easier than ours, in America, it's a forever license here, right? It essentially says, what's your MD equivalent? And then just like in Togo, they ask just for some pictures of your documents. Show us your medical degree. This is for anyone. MD, doesn't matter what degree you have. Should prove to us you went to med school, then you have to show that you're medical license in your country, and then like your little printout. And then St. Vincent is a lot easier. So the Minister of Health is obviously a good friend of mine. I just sent a picture of a passport and my medical license, and I have a medical license within 12 minutes. And then when Dr. Miulli, whoever was calling me, same process, a little text. And then she will register, we're fully functioning doctors in 12 minutes. Kenya takes about 6 weeks. You submit everything on a PDF, you send someone there, they ask for bribes, no, what's your name, I'll call the minister, with a little song and dance, and before you know it, your license eventually. And it's a fully functioning license. So it's just they're aware that there's so many things out there. So I've never been asked about it, because there's so many different degrees. They just want to make sure you're an actual doctor, not, when you read about the news, how this one girl was in West Africa, she was in a nursing student. She was in a nursing for 6 months, opened a clinic, and like thousands of kids died. And then she just left to go back to Virginia, actually. And she never got prosecuted, because he would go back to the country, right? So because of that, they are very strict now, especially in the sub-Saharan countries. So they are suspicious of foreign doctors, so they do have more vetting than St. Vincent does. Because once that person leaves, there's no accountability. So they do make sure you are a legit doctor.
Just to add, we know that we've got the 2 different degrees here in the States, and of all of the different degrees, the only 2 fully licensed physicians in this country are MDs and DOs. So there is no difference in what we can do versus what an allopathic physician can do in our licensure. And in fact, we've had surgeon generals in this country who are DOs, right? So kind of little known fact, but if you look at the credentials, credentialing. And that differentiates us from other osteopathic schools. For example, I think Dr. Lee mentioned it earlier, or Dr. Patel, I can't remember, but there are osteopathic medical schools in Europe. So if you train in England as a DO, they are strictly limited to osteopathic manipulation. They are not fully licensed physicians. So when we talk about our osteopathic training, it's very specifically American osteopathic training because we are fully licensed physicians.
Are there initials after the name DO in England?
Are the initials?
DO?
Yeah, I mean, that's,
In England, okay.
yeah. But again, you have to specify that it's American training versus European or Australian, etc. We've made tremendous inroads in having our full licensure starting to be acknowledged worldwide. And the AOA and the ACOS have been instrumental in doing that. But again, it's showing our credentials, showing our training, and especially since the single accreditation process, right, where we're sitting there going, well, I did residency with MDs, and my preceptors and my mentors are X, Y, and Z, right? So there's become more of a single pathway in a way, and which I think is going to make it easier for future generations. But certainly from our beginning, I think as we mentioned, AT still was an MD. So the principal basis of the osteopathic profession in the U.S. kind of grew out of the MD position that started it. And it's a philosophical difference, which I don't want to take up too much time. I'm happy to talk to anybody about the philosophical differences between an MD and an MDO. But in practice, we are fully licensed just like MDs and basically do the same.
Thank you. Anyone else have any other questions? Thank you. Excellent.
Does anyone do a laparoscopic course with you?
Anybody last